Okay, welcome everyone. We're so happy that you're here to join us today. We're excited to have this presentation and look forward to the questions and answers that you'll all receive. I'm going to turn it over to Morgan, my co-administrator, who will read the disclaimer.
Okay, so by participating or listening to this content, you agree not to use the information presented here as medical or legal advice in treating any medical condition. This forum does not constitute a physician-patient or attorney-client relationship. The content here is for informational and educational purposes only, and because each person is so unique, please consult your healthcare professional or attorney for any medical or legal questions.
Thank you, Morgan. I'd like to take the opportunity to welcome Nancy L Cavey with Cavey Law. She's taken the afternoon to speak with us, and I've already thanked her. I know she's answered a lot of the questions that you guys have in the chat. So please help me in welcoming Nancy Cavey.
Well, thank you for having us. I'm going to be speaking today on autonomic dysfunction, POTS, MECFS, MCAS, EDS, and your eligibility for Social Security disability benefits. So I've got a lot of slides to go over, and we're going to take a break after I go through the Social Security portion of the presentation. I'm going to talk about each of these medical conditions specifically and individually and collectively, so that you understand how what I've taught you about Social Security applies to each of these medical conditions. And we're going to be taking questions at the end. I too have to give a legal disclaimer. This presentation does not create an attorney-client relationship with myself or my firm, and it doesn't constitute legal advice. But with that, let's get started. The topics I'm going to talk about are Social Security disability and SSI, the 5-step sequential evaluation, the claims process, winning a claim and proof problems, how attorneys get paid, why you need an attorney, and then I'm going to go through all of these medical conditions individually, and then we'll talk about the interaction of them. And as I said, I'll take questions at the end. So let's get started with the wonderful world of Social Security. There are 2 types of Social Security benefits. The first is Social Security disability, and the second is supplemental benefits, SSI. Social Security disability is an insurance program. It's a disability program that's based on the payment of your FICA taxes of 20 out of the last 40 quarters prior to filing an application. Now, the number of quarters vary based on your age, but for the most part, it's 20 out of 40 quarters. That means that you're insured, but you need to understand that the insured status will end, and it will generally end about 5 years after you last work and your contributions cease. So it's really important that we are timely filing for Social Security disability. As you'll hear, as I explain later, it's going to take a year and a half to 2 years to get through the claims process. And if for some reason you're able to go back to work, that's great. But if you lose your insured status in this standpoint, you'll have to prove that you're disabled from the day you claimed your disability benefits, and then the day you lose your insured status. So we'll talk about that more if anybody has any questions. That's why it's important that you timely file a Social Security disability application. Now, SSDI will pay benefits from the 6th month of disability or 12 months before the application, whichever is later in time. SSDI is going to be paid based on your earnings history. It'll pay a maximum of $3,627 per month. Social Security uses what's called ACE, average current earnings, and we'll look at your 5 highest years' earnings to determine the amount of your benefits. There are no increases, if you will, except for COLA increases. So whatever your SSDI benefits are based on your earnings record is basically what it's going to be. Now, you also become eligible for Medicare after 29 months of disability. So the first 5 months, you don't get any benefits, even though you may be found to be disabled. That's true for everybody. And then you have to be on Social Security disability for 24 months before you became eligible for Medicare. So that's where we get the 29 months. Now, SSI is available to anybody who's legally in the United States, but it's an asset-based test. So you can only have $2,000 if you're single, or $3,000 if you're married in assets. Cars and house are not included. You get instant Medicaid, and the monthly payment is capped at $914 per month. And you can have to maintain your assets within these asset levels, or you can lose your eligibility for SSI. So now we've set the parameter for SSDI, SSI. And before I move on, most doctors understand that SSDI is something that you've worked for, you've contributed to. There are some doctors who think that SSDI is welfare, and they don't want to support welfare queens or kings. I try to educate physicians about their misconception about that and say, look at your own pay stub. You'll see where you have these FICA withholdings. And doctor, I'm sure you don't think that you're a welfare king or queen if you were to apply for benefits, because you've been contributing to this system. So what's the 5-step sequential evaluation? We have to start out with the definition of disability. And just because your doctor says you're disabled or you think you're disabled doesn't mean that you meet the Social Security standard for disability. It's a term of art. It's defined as the inability to engage in any substantial gainful activity by reason of any medically determinable physical or mental impairment, which can be expected to result in death, or which can last or can be expected to last for at least a continuous period of not less than 12 months. So there's a lot of words in this definition, and we're going to break some of these down so that you understand how this definition is actually applied in practice. Now, on this screen, you can see the 5-step sequential evaluation, and it is just that, sequential. If you don't meet step 1, you're denied. If you don't meet step 2, you're denied. If you don't meet step 3, you're not denied, but we go on to steps 4 and 5. If you don't meet step 4, you're denied, depending on your age. And if step 5, if you don't meet that test, you're denied. So we have to go through every one of these steps, but at any one of these steps, with the exception of 3, you can be kicked out. So I'm going to break this down in layman's terms. The 5-step sequential evaluation basically says, are you working? 2, is your medical condition severe? 3, does your medical condition meet what's called a listing? Number 4, can you do the lightest and simplest job you held in the last 15 years? And 5, can you do any other type of work in the mythical, hypothetical, not real world of work that you wouldn't want to do and doesn't pay a living wage in view of your age, your education, the skills that you have learned in your past work, and your functional abilities, your restrictions and limitations. Now, let's talk about step 1. Are you working? So the question becomes, does your medical condition prevent you from performing substantial gainful work on a full-time basis, earning less than $14.70 per month? So you can work, but if you earn $14.71, you're not eligible for benefits because you have exceeded the what's called the SGA. Now, I have clients that bouncing back and forth above that level. I don't like that. I think it makes it more difficult to win a case. I prefer that my clients really keep it well below the $14.70, because the judge will say, well, you know, you're $100 close, you're $13.70. Why can't you work a couple more hours or a couple more shifts to get over $14.70? And if you bite on that and say, well, you know, I could do that, the judge is going to rule against you. So if you're going to work, please keep it under $14.70. Number 2, is your medical condition severe? Now, this is designed to weed out cases where there's only minor limitations on your ability to work, or where your medical condition won't significantly limit the ability to perform basic work activity for at least 12 months. So that 12-month period is an important consideration. Sometimes Social Security will say, well, we think you're going to get better in 12 months, so we're not going to deny your claim. And that can be a hurdle for people who have slow progressing medical conditions, or which vary in intensity and frequency. Number 3, I'm going to take us back to biology. When we studied biology, we learned biology in terms of body systems, and the Social Security Administration takes a systems-based approach to the analysis of a claim. There's a book called the Blue Book or the Listing of Impairments, and we can open up various sections to see whether or not potentially the medical condition qualifies as a listed condition, and if so, whether or not people meet the listing. Now, medical records have to document the elements of the listing or the medical equivalent of a listing, but as I tell my clients, doctors didn't go to medical school to write a report that meets every element of a listing if your medical condition has a listing. So the majority of the time, while I try to develop an impairment at the listing level, the reality is these cases are decided at steps 4 and 5 of the 5-step sequential evaluation. Now, as I said, you have to meet every element. And if you meet every element at step 3, your benefits are automatically awarded. And if you don't, then we go on to address how your symptoms impact your ability to function. My clients love 2 words. I have them drilled in their heads: symptoms and functionality. Now, I think that is it really crucial that you ultimately get a form filled out by your physicians called residual functional capacity forms. If your medical records don't address, and most don't, your level of functioning, Social Security will do one of 2 things. They will have a consulting physician review your medical records. And you can imagine that they're being paid by Social Security, and they're not necessarily inclined to say that you are unable to do sedentary work, and generally say that you're able to do light work. Most of these doctors haven't been practicing in a million years, but that doesn't mean that Social Security won't recognize their opinion. So I always want my client's physician to complete a residual functional capacity form. Now, these forms were developed by lawyers generally, but Dr. Trevino's great PA has developed a POTS residual functional capacity form. And I think it's fantastic. And we have adapted it and we use it in our practice. By the way, I have a nationwide practice for both Social Security and ERISA disability benefits. And we use that POTS form regardless of where our clients live and regardless of whether or not it's a Social Security case or an ERISA disability case. Now, what's important about this form is that Social Security is going to compare your restrictions and limitations to the functional requirements of the lightest job you did in the 15 years before you became disabled, both physically, cognitively, and emotionally. And so at step 4, and I think at step 5, the key is to have this residual functional capacity form. There are many times I use more than one. It's not unusual for my clients to be depressed, have panic attacks. So I am going to ask them, if they're seeing a psychologist, psychiatrist, or mental health person, to get a psychiatric residual functional capacity form completed in addition to a POTS form or whatever applicable form that we can use. And as I said, many times we'll use more than one, because I never argue that there's just one disabling condition. I argue each condition individually and then collectively, because after all, you're a whole person. And I want the Social Security Administration not to parse your claim in terms of specific disabilities, but to see you as a total individual and consider the whole spectrum of disabling conditions. So, as I said, the key really is step 5. Can you do other work in the national economy, mythical, not real world, hypothetical, in view of your age, education, work experience, and your capabilities? I'm going to give you a little shorthand key to winning so that you understand what it is you need to prove. Now, generally, if you're under age 50, you have to be unable to perform sedentary work. And as I explained to my clients, it's the ability to lift maximum of 10 pounds, sit 6, occasionally walk and stand 2 hours out of an 8-hour day. Now, I'm sure you all say, well, I can't even do sedentary work. It's very hard to get the Social Security Administration to buy that, particularly if we have a younger individual. But there are ways that we can get around this particular bias in sedentary work. Many times, Social Security and the judges will say that you can do light work, and I'm going to use a technical term. We have to erode that ability to do light work so that basically we destroy the ability to do it on a full-time sustained basis. Now, if you're under age 50, I have to tell you, and particularly if you're in your 20s or 30s, there is a significant bias that Social Security has against younger individuals. They think that because a person is young, they can be retrained, they can go to school, they can learn simple routine tasks and work at a job like McDonald's. These cases are winnable. I just won a case 2 weeks ago involving a 23-year-old woman who had POTS. So each case obviously is unique. And when I get a case where I have someone under 50, I'm very well aware of that bias, and I'm working hard to help overcome that bias in our RFC forms and our medical records, the forms that you fill out, and your preparation at trial. Now, if we go to a hearing, you need to understand that first, the judge is not bound by any earlier denial. So the judge gets to exercise their own independent judgment. Most of the time, there are just two witnesses, you and the vocational evaluator. And with all due respect, they don't want to hear from your mother, father, brother, sister, best friend. They're not interested in any of that because they think those people are biased. Now, that isn't to say in the right case, I don't use them, but it's going to be you and the vocational evaluator. There might be a medical claims examiner or a medical examiner who will be asked to testify. Now, at the hearing stage, which is about 45 minutes, the hearing is about 45 minutes, and we do these days by phone or by Zoom. Very rarely are we having in-person hearings. The judge is going to give that vocational evaluator, that other person, a hypothetical after you testify. First 30 minutes you, last 15 minutes the vocational evaluator. And you're not going to understand the language, and it's going to go really, really quickly. But they're going to give a hypothetical about your age, education, skills, and the answers, well, the hypothetical and the answers to that hypothetical will make or break your case. And I'm going to talk about that later, and I'm going to actually give you an example of how this hypothetical works. But that is an overview of the 5-step sequential evaluation. So now we've sort of got the overview. Let's talk about the claims process, and that's confusion, delay, and denial. I have some other words that I use for it, but there's a 3-step administrative process. There's the initial application, the request for reconsideration, and the hearing. The IA is sent to a state agency called the Office of Disability Determination Services, DDS. And I have a nickname for them. It's Dumb, Dumber, and Stupid. That's a joke, but it's not a joke in that because of staffing issues, because of the lack of training, there's about a 90% denial rate. Now, that denial is also something that you contribute to, and that is no doctor records, no doctor support, a failure to accurately describe your symptoms and functionality, a failure to accurately describe your work duties. And I promise you, if you don't have doctor records or doctor support, there's a good chance that Social Security in the initial stage is going to send you out for a consultative medical exam, a CME. You got to go. But it's not unusual for an unqualified doctor to perform that. I recently had a pediatrician perform a CE in a case, and obviously I'm objecting to the weight of that opinion because a pediatrician doesn't know a whole lot in this particular case about a back condition. So you got to go. Social Security does look at it, and if the judge is looking for a reason to deny the claim, they will give significant weight to that consultative exam and ignore what your doctor has to say, because there's no treating physician role in Social Security. They're not bound by what your doctor has to say. The initial application is confusing, it's time consuming, it's easy to make errors. In my office, we actually help the clients complete the application, and it's a pain, but it's a process that needs to be done, particularly making sure that you have all your doctors listed. More importantly, you're given a good work history. When you look at the work history form, by the way, you'll see that it only asks questions about the physicality of your occupation and no questions about the cognitive aspect of your work and no questions about your interaction with others. I call it the psychosocial aspect of your work. So on the back page, the blank page of the work history form, I'm making sure that my clients are describing those types of duties. Now, right now it's taking about 250 days. In some parts of the United States, it's longer, and it's taking that long just for them to assign a claims examiner. So in that process, you need to continue to get medical care. We still want to be submitting those medical records and forms. Now, if your claim gets denied, as 90% of them do, you have to file what's called a request for reconsideration, and you have to do that within 60 days of the day of the decision, or you get to start all over again. It's reviewed by DDS, and they didn't get any smarter, and we still have that 90% denial rate. It's about 150 to 250 days to get a decision. And again, you can make mistakes. If you're getting new diagnostic studies, you're changing doctors, you're getting a new kind of treatment, there's been a change in your functionality, all that information should be submitted to Social Security. So once they finally open up the file, hopefully they'll look at the records and there's this additional information that should make a difference. If the claim gets denied a second time, the third appeal is called a request for hearing. And you got to file it within 60 days of the day of the denial, or you get to start all over again. Again, it can take 16 to 24 months or longer to get a hearing from the time of the initial application or longer, depending on where you live in the United States. The judge is going to be using the 5-step sequential evaluation, and they're not bound by that earlier denials. And the approval rates will vary by judge, unfortunately. 45-minute hearing, and in 45 minutes, you've got the first 30 minutes to put on your case. In my particular situation, what I think is key is the lack of claim development and the lack and preparation. And so I'm going to talk about this in our next slide. There are common proof problems that are going to sink a claim. One is generally not having a residual functional capacity form and an unfavorable CME exam, incomplete forms, failure to cooperate with the Social Security Administration. So they say, we're going to send you to a CME, and you say no, or they send you forms and you don't fill them out. You don't return their phone calls. Your medical records don't tell the story of your symptoms and functionality. You don't have residual functional capacity forms, the right ones, or them not completed properly. And then there's a lack of proper claim development and a lack of preparation. I explain to my clients that claim development starts with you. I like my clients to do what I call a symptom and functionality worksheet that we like to look at before each doctor visit. We want to give the doctor a really good interval history of what are your symptoms and how those symptoms impact your ability to function with some examples. So, I have difficulties rising from a chair, and 5 times out of 6, I'm going to fall down. And if I fall down, I've broken my wrist, I've broken my elbow, blah, 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 type thing. So what is a symptom, and how does that symptom impact your ability to function? I can't stand up at the sink to even wash off a coffee cup because I get faint, my heart rate drops, my blood pressure, changes, and down I go. So think about your symptoms and think about how your symptoms impact your ability to function, and make sure that story is being told in your medical records. Now, the other part of the claim development, again, is that RFC form. If you're at the hearing stage, lack of preparation can be fatal. You can't go in and watch a Social Security hearing. So I've shot a mock Social Security hearing video, so my clients get to see it. But unfortunately, some people won't meet their Social Security lawyer until the hour before the hearing, and that's not how it should go. You should be working closely with your Social Security attorney's office and the attorney. 6 weeks before a hearing, in my cases, I send out something called the direct examination video. It's an hour-long video that goes through every question one potentially could be asked, and I'm teaching people how to truthfully and accurately tell their story. But we also have a direct exam worksheet where my clients will write out all the answers to those questions and an updated symptoms and functionality worksheet. Then, as part of this preparation, I have a practice session with them. I go over the logistics of the hearing, but I play the judge, they play them, and we practice those answers so that they learn how to testify and explain all of the things that need to be explained in 30 minutes in a way that the judge understands. So lack of preparation, lack of claim development can be fatal. As part of that preparation, I do a memorandum of law, 5 pages long, and that's all we can do. And obviously, I'm there making sure that my client's testimony is accurate and complete, and I'm there to cross-examine the vocational evaluator and explain what it is the theory of the case is. Now, let's talk about these in greater detail. Inaccurate forms or incomplete forms, not completing them, not considering all of the disabling medical conditions, not providing complete medical information about the providers, the kind of diagnostic studies you've had, not providing medication information. And on the other side, we've got inaccurate work history. We have inaccurate information about the date of the disability, and we have inaccurate information from third-party sources. You're going to be asked to name some people who will be asked to fill out some forms, and I've seen what these people's forms have done to claims. They can destroy them because ultimately a judge has to determine your credibility. And if the judge thinks that you and your third-party source statement are exaggerating, then the judge isn't going to believe you. And the judge has the ability to determine your credibility, which can sink your case. Failure to cooperate, failing to call them back, failing to attend consultative exams, failing to attend a hearing. Medical records. I have a new medical term for you. It's DDD, Document Deficiency Disease. And if you've ever read your medical records, and I read a lot of them, sometimes you have to translate the medical records into English because they're very vague or incomplete. I try to make sure that the records are telling a story. And that might mean that we are supplementing the chart with that symptoms and functionality worksheet that I want my clients to fill out and be made part of the client's chart. Of course, the residual functional capacity form is crucial, particularly if the chart notes are deficient. But I will tell you that judges will say, well, how did we get from that chart note to this RFC form? Because I don't see this in the records. So the question is the chart clear? Is it generated by CPT codes, ICD-9 codes? Is it menu generated? Can you read the handwriting? Now, this all assumes, of course, that your doctor supports your claim. And if the doctor does not support the claim, it is my legal advice that you find another doctor, because you cannot win a claim generally, particularly these kinds of claims, without the support of a physician. Now, this is something that you need to be very careful about. You may be asked, well, how are you doing? And you might say, oh, I'm feeling better. Any new complaints? No, I don't have any new complaints. Any changes? No, my condition's the same. Well, that's vague. And that kind of language can be seized on by a judge as an indication that you've recovered and you're able to work. So I don't ever say feeling better. I feel fine. There are no new complaints. Make sure you're telling the doctor what your symptoms are and the functionality, and if possible, have that supplemental form as part of your medical record. Now, I think a good chart requires teamwork with the patient and the doctor, and it requires comments on functionality. In terms of exertion and non-exertion, what do we mean by exertion? That's pretty clear. Sit, stand, walk, stoop, bend. lift. Non-exertional is the need to alternate sitting and standing. Problems with bilateral manual dexterity, problems with pace, problems with concentration, problems with attendance, those kinds of things. And so if you're having trouble with sustained activity, you might want to say, you know, I can only get out of bed for 30 minutes and I'm fatigued and I have to take a nap for 15 minutes and I have to take, and that happens, you know, 5 times a day. So you're telling the doctor what the symptom is, the fatigue, how it impacts the ability to function. So a good chart should comment on your functionality and tell us true story without the need for a translator. The RFC form, you have to have the diagnosis as a basis of the diagnosis. We have to have a report of the symptoms. We have to have a report of the physical functional limitations, the cognitive functional limitations. And if it's a psych RFC form, it'll be much the same, except for it'll be the psychiatric functional limitations. So non-exertional impairments are really important to be developed in these cases. So postural limitations, manipulative limitations, environmental limitations, smoke, for example, mental and sensory impairments. You might have to alternate sitting, standing, elevate your legs. You may have difficulty bending, stooping, squatting. All of that should be in your medical records, but should be addressed in that RFC form, because ultimately we have to prove, for the most part, that you can't even do a sedentary job doing bilateral manual dexterity, maintaining the pace, production, and attendance requirements. So I'm always cognizant of, when I'm listening to my client, what are the complaints that they have that we can use to establish that they can't even do sedentary work. So if you've got difficulty with reaching, grasping, handling, fingering, relating to others, understanding or carrying out simple instructions, if you have problems with concentration or poor stress tolerance, those are the kinds of things that we want to be developing in your medical records. And as an aside, I want to tell you that many of my clients, as I said, are depressed and have problems with anxiety and panic attacks. Unfortunately, the Social Security Administration thinks that everybody's depressed and that, notwithstanding that everybody can work. So it's very difficult to win a pure psychiatric claim. And so I'm always wanting to develop both the physical problems my client has and the psychiatric or psychological problems they have, or the cognitive problems. I will tell you that judges will reduce those things to carrying out simple, routine, repetitive tasks. Simple, routine, repetitive tasks with minimal contact with the public, coworkers, and supervisors. So unless you're having psychiatric problems that are causing you to be Baker acted or institutionalized, the psychiatric complaints in and of themselves are just not going to be winning the claim. So your doctor's job is to assist in developing the evidence, making sure your story is told accurately and completely. And that's important because the judge is going to use that RFC to form the basis of the hypothetical. Now, I'm going to go and tell you a little story. And this is a story I tell my clients. When we get in front of the judge, there will be you and there will be a vocational evaluator. And that vocational evaluator will never have met you. They will have read your work history form. They will have listened to your testimony. And the judge is going to say something like this. Mr. and Mrs. V.E., I want you to assume that this individual who has a prior work history of working in the software industry can sit for 6 out of 8 hours, stand 2, lift 10, but because of cognitive and physical issues is going to be off task at least 10% of the time. Mr. or Mrs. VE, could they go back to that kind of work? Well, the VE is going to say no, because while everything is generally light to sedentary based on a hypothetical, the one thing that throws it off is being off task at least 10% of the time. And in that industry, you got to be 100% on 100% of the time. That question was step 4. But now comes the $1 million question. And the $1 million question is, well, Mr. and Mrs. VE, based on that hypothetical, is there other work that this person can do in the mythical, not real world national economy in view of their age, education, skills, and my hypothetical? And the VE is going to say, Judge, they could work in a laundromat folding towels all day. Judge, they could work in a room all by themselves, addressing envelopes all day. They could work as a phone solicitor. Judge, they could even work at the local restaurant putting silverware in that nice cloth napkin. If the judge stops there and your lawyer doesn't ask any questions, you're going to lose, because that question was step 5. But if I say, whoa, wait a second, I want you to assume that this person can't engage in postural changes more than just 1/3 of the time. So turning right, left, up, down, standing up, they can only at best do that 1/3 of the time. I want you to assume that they have issues with their hands. They are having some problems manipulating things. So they can only do manipulative activity for 1/3 of the time. And, because of their fatigue, because of side effects of medication, they're actually going to be off task at least 15 to 20% of the time. And, because of all the constellation of their symptoms, they're not going to be able to meet the attendance requirements, and they're going to be missing at least 2 days of work per month. Now, Mr. and Mrs. VE, as we add these things to the hypothetical, can this hypothetical person do the jobs you identified or any other work in the national economy? And the answer should be no. But this hypothetical is got to be formatted to meet your specific medical conditions and what potentially a judge would find as your restrictions and limitations. And many times I'm taking my hypothetical from not only my experience, but from the residual functional capacity forms that are being filled out by the doctors. So I'm adding things to the judge's hypothetical. I'm doing my own hypotheticals. And ultimately, it comes down to what the judge is going to make of your credibility and what hypothetical they go with. But I'm also, as many lawyers are, setting this up for an appeal if a judge rules against you, because many times the vocational issues can be a good fodder for an appeal if a claim gets denied. So we've talked about the 5-step sequential evaluation and the 3 stages of a Social Security case. So how do people like I get paid? Well, it's 25% of the back benefits up to a maximum of $7,200. The fee was raised in November of 2022, and it comes from back benefits. So I have an example here on the slide. If in this particular instance, the person is disabled as of January 1st, 2022, there's the 5-month waiting period. That ends May 31st, 2022. Benefits are paid in May of 2023 at $3,000 a month. 12 times 3 is 36,000. 20% of that is 9,000. So the fee is capped at $7,200. It's a one-time fee. Now, people can petition for a fee that's higher than the 25%, has to be approved by judges, and judges aren't necessarily automatically going to be approving a fee request in excess of the maximum fee. There are costs that are incurred in cases. Some lawyers will advance costs. I don't advance costs. I do ask that they be reimbursed at the end of the case. And costs are basically the cost of getting the medical records, because you can't win without getting the medical records. As I said, it's a one-time fee. So when you get your benefits, you're not going to be paying or shouldn't be paying your lawyer a monthly fee from those ongoing benefits. If you change a lawyer, generally the lawyers will work out the fee entitlement. And that's particularly true if, for example, you have an ERISA disability claim and the disability carrier has said, well, we recommend that you use this particular company, which I don't recommend, but ultimately you choose another Social Security ERISA disability attorney, then I end up dealing with that as anybody else would, deal with that fee, and many times they'll just waive their fee. So you're not going to have to pay a double fee. I want to make that clear. If there's a fee dispute, generally it's between lawyers and it's addressed generally by lawyers, and rarely does the court get involved because the lawyers will get it resolved. Now, why do you need an attorney? Abraham Lincoln once said, "A person who represents himself has a fool for a client." Now, I am a highly specialized lawyer, but if I were to need a will or an estate, or I was going to buy a piece of real estate, I would not be representing myself. I wouldn't be doing my own will. I wouldn't be doing my own estate. I wouldn't be doing my own closing because I don't know anything. Even though I'm a lawyer, that's not my area of specialty. You may be the smartest person in your family, in your industry, but I assure you that when you are disabled, you don't have either the physical or the cognitive stamina to really do this right. And I will tell you, Social Security is not your friend, and they're not in the business of paying benefits. If you think you're going to, be at the mercy of the judge and the judge is going to see how disabled you are, that's not going to happen. The judge is going to apply the 5-step sequential evaluation over and over and over. So regardless of how disabled you think you are, regardless of how obvious or not obvious it is, you can't count on the Social Security Administration or the judge to do the right thing. The win rate with lawyers representing people is higher. We take them on a contingency fee basis, so no fee unless we win. And there is no fee, by the way, as we're handling the claim. Cases, these are very medically and vocationally complex cases, and they're very poorly understood by the Social Security Administration. And I'll tell you more about that. And for the most part, as a practical matter, they don't have any protocol for evaluating these cases. And many times, as I've said, there's just not the proper case development of the records and the right RFCs. There's not a proper preparation of the client. There's not, you got to have a brief written, and, a 5-page brief sounds pretty simple, but in fact it's not, because you have to point to the verse and page, if you will, of the medical records to establish that you might need a listing, or support the fact that you have restrictions that would preclude you from doing your past relevant work or other work. And of course, you need representation at trial. And many times if you show up unrepresented, the judge will suggest strongly that you get an attorney, and we'll continue the hearing until you do that. And of course, you don't know how to cross-examine a vocational evaluator, regardless of how many times you've seen a legal show on TV. So the other thing I talk to my clients about is what's at stake here? What's at stake here are monthly benefits from the end of the waiting period until the retirement age. So if you're getting $4,000 a month in benefits, that's $36,000 to $48,000 a year. And even if you're getting $1,000 a month, 1,000 is 1,000 is 1,000, which is better than zero. You also get cost of living adjustment benefits, and as you may know, there was a huge increase in benefits because of the large COLA. And of course, once you become eligible for your Social Security, disability, or SSI benefits, you are getting lifetime medical benefits in the form of Medicare or Medicaid. And that, to me, that's a lot at stake, particularly in today's environment. So that's why I think you need to have an attorney. So how about if we take a break, and then I'm going to get into the various medical conditions, and we're going to talk about each one of them, how Social Security views them, and I'm going to give you some tips for how I think they can be won.
Great. Thank you, Nancy. Why don't everybody take a stretch and maybe go to the bathroom, get something to drink, because we all need to be drinking. Oh, good. Look, as I said that, Nancy was. All right. Take a break, everyone.
Great. Well, welcome back, everyone. What I'd like to do now is to talk about each of the medical conditions that I deal with in this particular sphere. I am obviously not a doctor, but I think it's really important that my clients understand the disease process, and that you be represented by a lawyer who understands the nature of the disease, the symptoms, how it impacts your functionality, and how you specifically experience the dysfunction or the disease so that the appropriate records, medical records and RFC forms and your testimony are properly developed. So bear with me if you are familiar with this, but I want to kind of use this description of each of these diseases to kind of set the stage. So let's first talk about autonomic dysfunction. The autonomic nervous system, known as the ANS, controls the heart rate, body temperature, breathing rate, digestion, and sensation. It's basically the connection between your brain and body parts and your internal organs. And there are two types of autonomic nervous systems. There is the sympathetic and there is the parasympathetic, SANS and PANS. SANS will stimulate organs like the heart, liver, sweat glands, skin, digestive, and urinary system, while the PANS slows down that bodily process. So I'm always interested in hearing from my clients what problems they might have with their heart, their liver, sweat glands, skin, digestive, and urinary issues, and how that may vary depending on the nature of their symptoms. And as we all know, it can vary hour to hour, day to day. The autonomic dysfunction occurs when the nerves of the ANS are damaged, and that can be chronic and it can be worsened over time. Now, what's important about this, again, is, I keep on banging on the history of the symptoms and functionality. And because these problems will generally worsen over time, I think it's really good that you are giving an interval history of the progression of your symptoms. I represent a lot of diabetics. I'm very active in the PD community, and there are chronic conditions that also will involve autonomic dysfunctions. And in those cases, we're also obviously want our clients to explain the progression of the symptoms from a diabetic standpoint or from a PD standpoint. But when we have autonomic dysfunction issues, I always want a good history of those symptoms and how they impact functionality. Now, normally what we'll see is dizziness and fainting when standing up, known as orthostatic hypotension. And then we have heart rate issues, we have sweating abnormalities, we have digestive problems, urinary problems, visual issues. I know it can be very difficult to talk about things like urinary or bowel and bladder issues, but that is very important because the need to use a restroom, need to be close to a restroom, the frequency with which you have to use a restroom can impact that ability to maintain the pace and production requirements of full-time employment. So I want things like that really well developed in the medical records. Now, there are a number of different types of autonomic dysfunction. The primary ones that I will see are POTS and the neurocardiogenic syncope. I have cases where there are autonomic dysfunction as a result of autoimmune disorders, which we'll touch on later. So those are generally the three that we see in the context of a Social Security or disability claim. All right, so let's contrast this with autoimmune disorders. Autonomic disorders are not the same as autoimmune disorders, and autoimmune disorders are not the same as autonomic disorders. But if you have an autoimmune disorder, you can have an autonomic issue. Okay, and so autoimmune diseases arise from an abnormal immune response of the body against substances and tissues that are normally present in your body. Localized autoimmune diseases generally affect certain tissues or body organs. For example, Crohn's, diabetes. Systemic autoimmune disorder affects body systems, and that generally will involve multiple body systems, such as MS or rheumatoid arthritis. And a systemic autoimmune disorder is more complex because of the multi-body system involvement. And again, in a Social Security case, I want to develop every medical condition that I can to win the claim. Now, what I am seeing in autoimmune disorders, by the way, is a lot of post-COVID development of autoimmune disorders. I'm also seeing post-COVID aggravation of pre-existing autoimmune disorder. And I'm seeing post-COVID development of systemic body disorders and autoimmune disorders. So it's a really mixed bag that we're seeing with post-COVID issues. Now, again, without getting into a lot of detail, Social Security is going to want to see positive lab work and diagnostic studies that will confirm both autonomic dysfunction and autoimmune disorders. And generally, they are looking for positive lab work and other objective diagnostic studies to be found in the medical records. Let's talk about POTS. Now that we've sort of set the stage between the difference of autonomic dysfunction and autoimmune dysfunction, I'm going to go back to the autonomic issues. Because again, even in the cases where we've got the autoimmune issues, we are seeing autonomic issues, one of which is POTS. So Social Security does not understand the term POTS. They don't understand the symptoms of POTS. They don't understand the type and causes of POTS. They don't understand excessive heart rate increases in POTS, with particularly in cases where there is normal cardiac function, if you will, and they don't necessarily get the listings that are potentials in a Social Security claim. So let's take this word apart. Postural orthostatic tachycardia syndrome. So postural refers to the position of your body. So in your medical records, I would want to see you giving a history to the physician of problems that you're having with the positioning of your body. Because remember, we have to prove you can't even do a sedentary job. And most of the sedentary jobs involve postural issues, turning, twisting, standing, bending, stooping, that sort of thing. Orthostatic refers to the act of standing up. So what's happening to your body when you stand up? And of course, tachycardia refers to an increase in the heart rate. And the syndrome is the group of symptoms, the constellation of symptoms. And I would like to see in the medical records you basically breaking down your symptoms in terms of postural, orthostatic, tachycardia, and then any other syndrome symptoms that you have. That's the best way, I think, to tell the story. And that's what I'm telling my clients from the beginning. So Social Security doesn't get what each of these mean in terms of your symptoms and functionality. So it's up to you to make sure you're explaining that. Now, there are 4 types of POTS. Let's talk about neuropathic POTS. It's associated with damage to the small nerve fibers that regulate the constriction of blood vessels in limbs and the abdomen. And this can cause symptoms of dysfunction in the limbs and the gastroenterological system. And so there isn't a listing for POTS. So we go searching around for listings that we can try to meet. And that, of course, is in part based on your symptoms. So we can look at Section 11, the neurological listings, Section 5, the gastrointestinal listings. There's hydrogenic POTS, which is associated with a loss of the norepinephrine, that can cause tremors, cold sweats, extremities, migraine headaches, and increased urination. So I'm looking in the medical records for tremors. That impacts your ability to use both your hands, bilateral manual dexterity. Cold and sweaty extremities, obviously that would result in environmental restrictions. Migraine headaches can also result in restrictions and limitations because of the functional issues associated with the migraine, where you're flat in a cold, dark room. And urination, obviously, is the need to go to the bathroom. There is urological listings, but there aren't any listings for migraines. So as we break down your symptoms and the type of POTS, then we're looking at listings. Hypovolemic POTS is associated with low levels of blood. That causes weakness and decreased tolerance for activity. And there is no equivalent listing. But again, I'm into symptoms. And then there's secondary POTS, which is associated with other conditions, such as diabetes, Lyme, lupus, Sjogren's. And these can cause POT-like symptoms. And additionally, we're dealing with symptoms of the underlying disease. There's no listing for secondary POTS. So again, I'm looking at where can I potentially get them? Maybe I can get them in a lupus listing. Maybe I can get them in a diabetes listing. So again, 4 types, and we're trying to get as close as we can to a listing. Now, let's talk about the diagnosis of POTS. As you have all unfortunately experienced, not all doctors get POTS. In fact, very few of them I'm going to call the traditional mainstream doctors, family doctors, even emergency room doctors, neurologists, cardiologists don't always get POTS, and you'll present and they'll say it's all in your head or some other things. And so it's really important that you're treating with, being evaluated and treated with a POTS specialist. What's key for Social Security is the physical exam, any blood work, the standing test, or the heads-up tilt table test. Now, as we know, when you do the tilt test, what you are looking for is an abnormal heart rate response to being upright. Your symptoms worsen when upright, and you don't develop the orthostatic hypotension in the first 3 minutes. Social Security will pay attention to that, but even if you have a negative tilt test, doesn't mean that they're going to necessarily question the diagnosis, particularly when there are other tests that are corroborative of POTS. I always want to make sure that these tests are documented in the medical records. There have been times, quite frankly, when I've actually had to have a second read on the results of the tilt table test to show, in fact, that the cardiologist misread it. So again, I'm always looking at the diagnosis. Social Security is going to be looking at the diagnosis. Now, one of the things that is a bit problematic, as you know, is that there are similar medical symptoms of similar medical conditions. There's ME/CFS, there is fibromyalgia, and you will see an overlap of symptoms. And so they are generally looking for a rule out of those medical conditions. Though I've had clients who have all of that, all of these conditions in combination. So the key to winning a POTS claim is supportive medical records with your history of symptoms and functionality, objective testing of the diagnosis, objective testing that supports the RFC, potentially trying to meet the listings, figuring out backwards why you can't do your past work, and then making sure that we've got the symptoms and functionality that are true and accurate, but would preclude you from doing that past relevant work. If you're under 50, we have to show that you can't do even sedentary work, that there's been what we call an erosion of your ability to do that because of the need to alternate sitting and standing, naps, fatigue issues, concentration issues, pace issues, attendance issues. But ultimately, to win, we have to show basically less than sedentary, that you can only do simple, routine, repetitive tasks, and that the kind of work you can do is what we call unskilled, which is basically McDonald level type work. If you're over 50, we have to show sedentary and no skills. And again, just the words I'm using should be clues and keys to you that you need a lawyer to represent you in this case, because you probably didn't fully understand what we have to prove for PRW or other work, sedentary, unskilled work, transferable skills, all terms of art in a Social Security case. So let's talk about ME/CFS. They don't understand the term ME/CFS. They don't understand the symptoms. They don't understand autoimmune issues, and they don't understand the potential listings for impairments. So ME/CFS is a complex medical condition. It can be caused by infections, immune system challenges, stress, and possibly a genetic link. I will say to you, if there's any good thing that has come out of COVID, it is that ME/CFS cases are getting much more attention, and there's a lot of scientific attention being directed to the COVID virus, which is helping with the diagnosis and potential treatment of ME/CFS. There is no gold standard test for a diagnosis of ME/CFS. It's based on history and physical exam. It's sort of a diagnosis of elimination, much like fibromyalgia was back in the day. What is a primary symptom? Drop in activity level along with fatigue that lasts 6 months. The nature of the fatigue is important. So if you're having fatigue issues, it's the nature of the fatigue issue. It could be that you have unrestful sleep. You have to take naps. When you wake up, you feel like you're in a fog. So it's the nature of the fatigue that's important. that is being described in your medical records. Traditionally, you'll see a worsening of ME/CFS symptoms after physical or mental activity that wouldn't have caused a problem before the illness. It's known as post-exertional malaise. One of the ways that we measure it, particularly in my ERISA disability cases, is with something called a CPET exam, a cardiac pulmonary exercise test. And in the right case, we'll use that test, generally not in a pure Social Security case. ME/CFS is also associated with sleep issues. So those sleep issues should be documented, including, again, the nature of the sleep problems, whether you are using any kind of a CPAP, how compliant you are. I know that CPAP is associated with breathing issues, but again, Social Security tends to associate sleep problems with other sleep disorders, and they always jump to we want to know if your person is, using a mask. And in the diagnosis process, the diagnosis is also predicated on one of the two following symptoms: problems with thinking and memory, and worsening of symptoms when standing or sitting upright, back to our orthostatic intolerance. So you can see there's a lot of overlap between these. And when I'm dealing with a case, I'm trying to figure out, do I have a pure POTS case? Do I have an autoimmune disorder case? Do I have an ME/CFS case, or do I have a combination of them? Because I want to be developing the necessary medical evidence and the appropriate residual functional capacity for them. ME/CFS is seen with other common symptoms: pain in muscle and joints, headaches, digestive issues, irregular heartbeat, muscle weakness, shortness of breath, some of which are consistent with fibromyalgia. Now, many people with ME/CFS have autoimmune conditions like fibromyalgia, and they'll have POTS. But again, it's not, and I don't mean autonomic POTS. I mean basically autoimmune generated POTS. Someone, for example, who has MS. So again, sorting all of this out is important for Social Security purposes, because if I have a client who has multiple medical issues, or we're not quite clear in the diagnosis, I want to be arguing as many medical conditions as I can. So the key to winning an ME/CFS claim are the exam findings and symptoms consistent with a diagnosis, the treatment by a specialist. And in all of these cases, I will tell you, if you're just treating with a garden variety physician as opposed to a specialist, that will not help your case. The Social Security Administration, and particularly judges, expect that you're being seen by an expert. In an ME/CFS case, we, again, in select cases, will do the pulmonary exercise testing, and in select cases, we'll do neurocognitive testing that will support the complaints of problems with memory dysfunction. There is no listing for ME/CFS. So again, you're not going to win at step 3, much like POTS, you're generally not going to win at step 3. Step 4 and 5 are the same keys. Can't do past relevant work. Step 5, under 50, less than sedentary, simple, routine, repetitive, unskilled work. Over 50, sedentary, but no transferable skills. And again, as I'm listening and reading records, I'm trying to translate to how I can develop a winning theory to get my clients their benefits based in part on their age. Small fiber neuropathy. Again, we are seeing increased cases of small fiber neuropathy, particularly post-COVID. And Social Security really doesn't get SFN for the same reasons. They don't understand the terms, the symptoms, the causes, or potential listings. And so, again, I think it's helpful to step back. What is small fiber neuropathy? It is a disease, if you will, or neuropathy caused primarily by diabetes, but autoimmune disorders, Sjogren's, scardosis, some neoplastic syndrome diseases. And again, I'm looking for the diagnosis. The symptoms of SFN include pain and burning in the feet, trunk, or arms, electric shock level pain, lightheadedness, blood pressure will drop when sitting or standing up, loss of consciousness, sweating, gastroenterological issues. I am always, when I'm hearing these symptoms of pain and burning in the feet, trunk, or arms, going to, how does that impact a person's ability to sit? Can they sit 6 out of 8 hours? Do they have to get up? Do they have to move around? What do they do to address this electric shock level pain? Are they taking medications like, for example, gabapentin? And what are the side effects of that medication? Is it working, not working? Does it make them a little slow cognitively? Does it knock them out in terms of making them sleepy? So I want to develop, when I hear those types of things, the impact on a person's ability to sit, and certainly their ability to use their hands individually, right hand, left hand, right hand together, or hands together. Why? Sedentary jobs are based on this. That is the continual use of your hands in a bilateral manner, be it typing, be it one finger typing, if you will, manipulating things, assembling things, rolling silverware in that nice cloth napkin, holding a pen and writing things. Okay, now in small fiber neuropathy, there are RFC forms potentially that we've developed, but there's also a listing level impairment at 11.14 rather. You have to have motor function tests, EMGs, nerve conduction study tests, scans, that sort of thing. And for those of you who have had EMG and nerve conduction study tests, you know they're not particularly pleasant tests. Same key, past relevant work, other work. That's the game in these claims. And you always have to be thinking by each medical condition, how do I get a person to less than sedentary if they're under 50, or sedentary if they're 50 or over? Mast cell activation syndrome. Social Security doesn't understand it. They tend, particularly in my experience with judges, they're kind of glossing over it. They think it's sort of a basic allergic reaction, but they don't get the full nature of that reaction. So I'm spending a lot of time in trial with my clients, making sure we're talking about the symptoms and then talking about the combination, if you will. Mast cell activation syndrome really wasn't recognized by the CDC before 2017. And it occurs when mast cells, which are allergy cells responsible for immediate allergic reactions, trigger that reaction or an inflammatory response. And basically, the mast cells are secreting certain chemicals, if you will, that are being generated or triggered in response to whatever the particular pathogen is. What happens is these mediators are basically being released too frequently, and they're causing allergic reaction in various body systems: the skin, the nervous system, the cardiovascular, and the digestive system. And too often, Social Security and the judges tend to think that it's just a reaction on the skin, when in fact it's a multi-system reaction. And that's why I want that well documented in the medical records and well explained by my clients. So symptoms are chronic fatigue, itching and watering of eyes, nasal problems, shortness of breath, recurrent arrhythmias, low blood pressure, syncope, and POTS-like symptoms. So many times we're going to have an overlap of symptoms, but we may not have, for example, a POTS diagnosis. In POTS, we don't always have mast cell activation syndrome, though I see them a lot together. They're just not always presenting that way. Now, what I'm also seeing, and my colleagues are seeing, are Ehlers-Danlos syndrome, POTS, and the mast cell activation syndrome occurring together. Ehlers-Danlos, as I will talk about in a moment, is a congenital disease, but for some reason, particularly post-COVID, I'm seeing a presentation of an activation of Ehlers-Danlos syndrome, and certainly we're seeing POTS and MCAS. And so it's not uncommon to see it with autoimmune disorders, but I'm also seeing it in presentation or combination with genetic conditions. There is no listing The applicable listings can include an immune listing 1406 if we've got 2 body systems involved, 1 system moderately involved, and at least 2 of the following: severe fatigue, fever, malaise, or involuntary weight loss. Now, there can be other applicable listings based on other involved body systems, but when I have mast cell, I'm looking at listing 14.06. Again, what's the key? It's going to be those medical records with symptoms and system involvement. So you should be thinking about, okay, I have skin issues. Here are what they are. I have digestive issues. Here are what they are. Then I have everything else. Here are those symptoms. This is how it impacts my ability to function. So we're looking to break down in detail each one of these medical conditions in terms of symptoms and functionality, identifying the right RFC form, and then trying to work it in, if possible, to a listing. COVID-19. There are lots of things that Social Security does not get about COVID. I just tried one of the first COVID cases in Florida in April, won it. But before the hearing got started, and in this case, I had 5 different kinds of RFC forms. Before we went on the record, the judge said, look, Social Security has no position paper on this. They've given us no direction as to how we're supposed to evaluate this condition. What do you think I should do? And I said to him, I said, look, COVID clearly causes immunological issues. So let's evaluate any immunological issues or diagnoses that we think exist. It causes pulmonary issues. So if my client's got pulmonary issues, let's evaluate those. They've got cardiac issues. They've got digestive issues. So basically, I suggested to the judge that we back into this based on either the diagnosis or the system involvement, which is why I had the RFC forms. Ultimately, the judge agreed with me, and we won this case. So right now, I'm trying to do a lot of education of the judges in my memo of law or in my opening statement about how they should be evaluating a COVID case or a COVID complicated long-term COVID case. Now, I will tell you, they want to see a COVID-19 diagnosis, and that can be hard because particularly in the beginning, there were a lot of false positives. I can sometimes get around that based on sort of a post COVID-19 analysis of the medical records. And what I mean by that, when you look at the history that the person gives about their symptoms, how those symptoms progressed, and then what post-COVID, in quotes, body systems were involved. But let's say I have a client who has significant pulmonary issues. We obviously had to submit documentation regarding the underlying COVID diagnosis, but we were submitting pulmonary function tests to document the complications that he was having from a pulmonary standpoint. So again, you got to look individually and collectively at these medical conditions and develop the right medical history and RFC form. I will tell you, I think that POTS cases and COVID cases do take more preparation of the client because there are just potentially so many more symptoms. In other cases, I have a lot of overlap of symptoms. So when I've got overlapping conditions, I'm spending time with my clients trying to help them sort out what the disabling symptoms are. When I have combination cases, I try to silo them to begin with, if you will, and then in the medical records and in testimony, develop how each works individually and then in combination. Okay, Ehlers-Danlos syndrome. They don't necessarily get what it is. Listings are a little easier for them, but it clearly is not an autoimmune disorder. It's a genetic disorder. It impacts the collagen, and as a result, that impacts your skin, your blood vessels, your joints. It can result in hypermobility and over-flexible joints that results in dislocation. Any joint can potentially move beyond its normal range of motion. So I just tried a case last week, which is an EDS case. And this person would have chronically dislocated ribs. She would just roll over. And she would also have dislocated joints in her fingers. And she would have joint dislocation issues with her hips. So obviously, I'm talking and developing the medical records and the RFC forms to address the finger issue, manipulation. We're dealing with the ribs because that deals with postural issues, hip, the ability to sit. So again, not to be repetitive, it really is important that we're addressing those kinds of symptoms that would impact your ability to do even a sedentary job. The diagnosis is made using the Brighton score test and the nature of your symptoms. Social Security is going to want to see that. They're going to want to see this hypermobility, subluxation, and injuries caused by subluxation. There's no EDS listing, but as you can see here, there are at least 6 potential listings for an EDS claim. And the key to winning, again, is the test, the Brighton score testing, the family history of EDS, the development of the symptoms, examples of dislocations and injuries. And in this case, I do use family or friend statements more readily, and photos and video, because it's hard to fake a dislocated or subluxated limb. So I've given you a lot of information. Hopefully you found this educational, and I'm sure you've got lots of questions. So let's get right to it.
Nancy, thank you so much. This has been so informational. Would you like Morgan to read the question to you? Would that be the easiest?
Yes, please.
Okay. Morgan, take it away.
Alrighty, so the first question is, I received SSDI benefits in February of 2020. When should I expect my case to be reviewed again?
Okay, again, I'll give you my disclaimer. I can't give any legal advice, but generally what I will say to you are 2 things. One, well, let me back up. Social Security will review the decision, and internally they will determine how long they think it should be until the review process should be. It could be 1 year, 2 years, 5 years, 7 years. In part, it's based on the strength of your medical records, and more importantly, it's based on your age. The younger you are, the more likely it is to be a shorter period of time, a year or 2 year, because they're looking for improvement. So please, please, please continue to get medical treatment at regular intervals by a specialist, and make sure that you are continuing to give your doctor the history of symptoms and functionality, because Social Security will be scouring your medical records for any evidence of improvement. And if you say, fine, feeling better, that's going to be something that they're going to jump on and say, must be improved. Let's do a review.
Very good answer.
For the next one, if you already have benefits and you come up for reconsideration, how are the attorney fees paid?
Okay, so I think what you're asking me is that you are been set for what's called a continuing disability review. And Social Security is looking at the case to determine whether or not they're going to terminate your benefits. In that case, I take them on a flat fee, and that's how most Social Security lawyers will take them. I collect the fee, I put it in my trust account, and then ultimately I will fee petition the court for approval to take the money out of my trust account.
Thank you. Number 3 is, I started receiving benefits at 60. Will my benefits change at retirement?
So the name of your benefits will change. You will go from SSDI to Social Security Retirement.
And when and how do we get the RFC form?
Social Security will never tell you about an RFC form. A lot of doctors don't know about RFC forms, and that's one of the reasons why you want to have a lawyer, because not only is it, I could send you a POTS RFC form, but it's just not the form. It's how the form is filled out, and whether that form is consistent with your medical records. And picking what other RFC forms should be filled out. So again, each case is generally, case specific. And generally, in my experience, you should have more than one RFC form. But one of the ways that judges or the Social Security Administration will reject them is the lack of consistency between what's in the medical records in terms of symptoms and functionality, what's in that RFC form, and potentially what's in third-party statement forms. So what's important here is this consistency between all the documents.
Interesting. All right. And then what do I do if I move to a different state from where I originally filed SSD form with an attorney?
So if your claim has not been decided, one of two things can happen. If I already have a hearing set and I know the judge and like the judge, I'm going to try to keep that hearing, for example, in Florida. If I have a client who moves to North Carolina and the treating doctors are in North Carolina, then generally, I have no objection to moving it to North Carolina. Social Security is a national practice, so lawyers can practice all across the United States. And unless there's some specific reason I don't want to continue to represent the client, I will generally continue to represent the client regardless of where they live.
Awesome. Okay. I worked as a younger person, stopped while my kids were little, and then have been too disabled to rejoin the workforce. Am I eligible for benefits based on my last income related to my spouse's income, or am I just out of luck altogether?
So that's a great question. Remember when we started, I explained that you have to work a certain number of quarters to become insured. That's question number one. So were you ever insured? Question number two is, when did that insured status end? Number three is, how long were you out of the workforce? So if you were out of the workforce generally more than 5 years from the time you last worked, you most likely are not insured. Social Security disability benefits are paid on your earning records, not your mother, father, brother, sister, spouse. So you very well may be uninsured for SSD purposes, and unless you meet the asset tests of 1,000 or 2,000, depending on your marital status, you very well may be out of luck.
Okay, thank you. And what does it mean when you've been stuck at stage 3 out of 5 for 8 months?
Do you mean step 3 of the 5-step sequential evaluation or step 3 of the claims process?
That's me. I was step 3 out of the 5 claims process. I've been there for quite a while.
So you're at the hearing stage?
I guess. I don't really know. Is that the hearing stage?
Yeah. So step 1 is the initial application, if you will. Stage 2 is the request for reconsideration. And stage 3 is the hearing. And if you've only been stuck there for 5 months, I'm afraid that I have to tell you, you're going to be stuck there for a while. The judges are not as backed up as the Office of Disability Adjudication and Review, but you're where you need to be, and what's happening is it's kind of moving down the treadmill, if you will, or the conveyor belt. When the judge's office is ready to schedule it for a hearing, the judge's office, the staff is going to get your medical records, put them in order. It's called exhibiting them. Then they will schedule the hearing, giving you notice, timely notice of the hearing. In this time frame, what you should be doing if you're not represented is get a lawyer, to continue to get the medical treatment and be submitting your medical records, get a residual functional capacity form or forms and submit them. I, as a lawyer, will do a brief as appropriate, asking for what's called an on-the-record decision. So in my brief, I'll go through the 5-step sequential evaluation and explain why I think either at step 3 you meet a listing, or step 5, why you can't do other work in the mythical, not real world national economy, and invite the judge to do what's called a fully favorable on the record decision. I just had that happen last week in a case. Asked for a fully favorable, and the judge felt that my client met the 5-step sequential evaluation, and the hearing was canceled.
Wow. Okay. All right. The $1,470 or $1,470 that you discussed, is that the max that someone should make that's trying to get benefits, or is that the maximum you can make if you already receive benefits?
Okay. So when we're in the application stage, if you're earning more than $1,470 per month, you're not eligible, regardless of how disabled you are, because that amount of money is determined to be significant gainful activity. So you get disqualified at step 1. As I've said, if you work, please keep it under $1,470. Now, once you're on benefits, you can potentially work, and there are a number of programs where you can continue to get benefits and work. There's trial work periods, there's extended trial work periods, and again, each case is factually unique. You should be putting them on notice of the trial work period or the extended trial work period, and you can earn more than the $1,470. But if you go, depending on what program you're in, more than a certain number of months, then you potentially lose your eligibility for your Social Security disability benefits. If you lose your benefits, you can potentially get them reinstated. But again, when I have a client who says, I want to go back to work, I always, suggest to them that we have a discussion about that and what program they're going to be in, and time limits and deadlines, and continuing to get medical treatment, that sort of thing.
If you're receiving SSDI, but your attorney did not include mental aspects of the disability, is there a benefit to going after those as well?
No, this is not like the VA. If you're a veteran, for example, you may be familiar with the VA system, which is based on different body parts anatomic impairment ratings. So you can get a 10% for your hearing, you can get a 30% for your wrist. Social Security does not use different types of rating systems or impairments to arrive at the question of whether you're disabled. So trying to go back and reopen a case because of mental impairment, 1, you generally can't, and 2, there's no point in it because you're not going to get any more money. You're going to get what you're going to get based on your earnings record. So be happy you won.
Okay. And let's see, how does one get representation? I used to have a lawyer and he left. No one's taking me up, and I've been unable to work since 2019. So does that mean my 5 years are past?
Well, again, you're asking me for a specific legal opinion. The first question I would be saying to you would be, you need to call up the Social Security Administration to find out what's called your date last insured. It's called DLI. So you want to know what your DLI is. If it's, if it's expired, then the question becomes, okay, and I'm just going to make something up here. Let's say you last worked in 2020 and your insured status, so you last worked January 1st, 2020, and your insured status ended January 1st, 2022, and we're sitting here filing a claim. You may not be able to go back enough, in time to be eligible for Social Security benefits. But if you are, then what we need to do is to actually look at your medical records in that time frame, let's say from 20 to 22, to see whether or not there is proof that would meet the 5-step sequential evaluation. So if you weren't seeing the doctor, you're not going to win. If you were seeing the doctor infrequently, probably not going to win. If you were seeing the doctor frequently and the records document symptoms and functionality, there's a shot at it. Again, it depends on each person's unique situation. And that's probably the best answer I can give you.
Okay, thank you. And of the illnesses mentioned today, is there one that is considered the easiest to get SSDI for?
No.
Nice and simple. I like that. Now you did mention that you do represent clients all over the country, correct?
Correct.
Okay, awesome. We have a couple clients up in Connecticut, or a couple patients up in Connecticut that were wondering
Yes.
if you'd possibly be able to represent them.
I have cases all over the United States.
Okay, thank you.
And
And
just one moment. What we'll do after the presentation, Jesse, who is on Nancy's team, has agreed to put a post in our group with some links to a lot of information and the information on how you can hire Nancy.
perfect. Okay, and then let's see. How do we know if our disability was considered permanent or when it will be up for reevaluation or reconsideration?
Yeah, so that's the question that I was asked before. As I said, the Social Security is going to look at the decision of the judge. Sometimes judges will actually make recommendations, and they'll internally determine when they think a review should be done. The younger you are, the more likely it's going to be 1 or 2 years. The older you are, more likely it's going to be 5 to 7 years. And again, each case is unique. I will tell you that there are times when there might be something in your medical records when they're doing a continuing disability review that leads them to say, oh my gosh, they're working. And that will definitely, trigger a more closely reviewed claim. And then they're going to check to see if you reported those earnings, which is why, again, if you want to do a trial work period, you should be consulting with your lawyer or consulting with the Social Security Administration, because you don't want to get a bill saying you owe us money, or a knock on your door with a question about whether or not you're committing Social Security fraud. So the review. So in essence, the review will depend on the nature of your medical condition, your age, and what Social Security internally decides they want to do in terms of a review.
Nancy, if you were approved at 60, what are the chances that they'll come back and do a reconsideration due to us being so close to retirement age?
As a practical matter, I rarely see CDRs, continuing disability reviews, done for people over 60.
Thank you.
Okay, and then how early in the application process do you recommend getting a lawyer?
Well, I think that a lawyer should be hired from the very beginning for a number of reasons. One, remember, we're not getting paid, but I want to be I want to be teaching my client how to tell their story in terms of their symptoms and functionality. Number two, I want to emphasize that they need to get continued medical treatment. Number three, I want to be saying, look, I want to get the appropriate residual functional capacity form. And number four, when we're submitting this application, I always try, unlike a lot of lawyers, to explain in the application why my client meets the 5-step sequential evaluation. So I'm always trying to give the Social Security Administration, DDS, and ultimately the judge, the roadmap from the very beginning, so that they can see early on why they should approve this claim. And they can see, if it's not at the request for reconsideration stage, the progression of my client's symptoms and functionality, the ongoing organicity, the objective basis of their medical condition. So I'm always trying to control the narrative from the very beginning. And it's the story of your symptoms and functionality that are the key, in my view, to getting your benefits and making your claim a winning claim.
This is a very, very important aspect of how special Nancy is, because probably 80 to 90% of the attorneys that you will call, that I called, told me they won't even speak to me till I filed myself and been denied. So kudos to you, Nancy, for helping people from the very beginning, because that was a struggle for me.
And that's in my view, it's a struggle that is a needless struggle, because there are mistakes, as I explained, that can be made in that initial application that can doom the claim. As part of the initial application process, you're filling out the work history form. You're also filling out forms about like pain questionnaires, and what you put on those forms can and will be used against you by a judge who's looking for a reason to deny your claim. And so even though you may have filled out that form 2 years ago, I see judges seize on what's in that form to say, well, back then, they could do this, this, or that. And I don't see anything in the medical records that explains what's changed. So I don't believe them. I believe that what they said at the time of the initial application about their activity level is what that activity level is today. So very early, you can make mistakes that are hard to overcome. So you want to prevent that, don't you? You don't want to have, as Abraham Lincoln said, a fool for a client.
The next question, is there a way to look up what other medical conditions are listed or would help with getting disability approved? And do you recommend including conditions that are currently doing better and are well controlled?
All right, so you can get on the listing of impairments. I urge you to go open the book, go read them, because you're going to be you're going to be overwhelmed and confused. But you can see that it's a pretty comprehensive checklist. And when you look at that checklist and you look at your medical records, you're not going to see the elements of a listing in your medical. As I've said, doctors did not go to medical school to learn how to write a report for you for your Social Security disability claim. So you can look all you want. The reality is that the majority of these cases are not decided at step 3. The majority of cases are decided at steps 4 and 5, where the issue of your functionality is key. Can you go back to your past relevant work? Can you do other work in the mythical, not real world national economy? And if your records don't address that, you're in trouble, because they're going to have a consultative exam, or they're going to have an internal review by Social Security doctors. And neither of those medical providers are in your, in your corner. So again, in my view, listing level impairments are very, very hard to meet. People get hung up on them when they should be focusing on symptoms and functionality, improving their entitlement at steps 4 and 5.
Christy posted in the chat the link to that. So if anyone does want to go check out the impairments, she put the link there.
And then are there any forms you suggest using, for example, for assessing interval symptoms and functionality to bring to doctor appointments with us?
So we've created a form called Symptoms and Functionality that we like to use. It's pretty simple. What are the symptoms? How does it impact your ability to function? And we generally like it by medical condition. In my migraine cases, I will have my clients get online and download a migraine pain diary. Same way with CFS, fibromyalgia, you can find all sorts of pain diaries or diaries that you can use. I don't like people to do them on a daily basis. I find it depressing. They find it depressing. This is not a daily narrative. In my view, it is an interval history of what happened over this period of time. Not this happened this minute, this happened today, maybe over a week. On a migraine basis, however, then I definitely want it daily, because these migraines occur daily. So I want to see that, as probably your physician wants to see it.
And does SSDI have to alert me that they are reviewing my case? And can they request my medical records without my consent?
So they don't have to notify you that they are reviewing the claim, though generally they do. And yes, they are contacting doctors, quote unquote, without your consent, but generally they will get releases because they've already had releases from you.
Okay.
And I'm going to add this. hiding medical records from the Social Security Administration is not a wise thing to do. That it's not wise for a couple of reasons. One is if you are getting medical treatment and you're trying to hide it and they find out, they're never going to believe anything you have to say. And credibility is key. Number two is when you're hiding medical records, you're also hiding the record of your treatment. One of the reasons why claims get denied is because of, and even, or CDRs happen, is because there isn't this continuity of medical treatment. So Social Security expects that you're going to get treatment and expects that you're going to get treatment on a regular basis from a recognized medical source. So I'm going to introduce another concept here. Social Security will only accept medical records or medical opinions, if you will, from an accepted medical source. Chiropractors, acupuncturists, herbalists, physical therapists, social workers generally are not considered acceptable sources. And so we still want to submit the documentation, but Social Security is not going to rely on anything they have to say. If they fill out an RFC form, it's going to be worthless unless it's endorsed by a medical provider. So in the case of a social worker, a treating psychiatrist or psychologist, PhD level, is going to have to sign off on it. So I know people like alternative medical treatment. I understand why they want to try the treatment, but you need to understand that that is not going to make the difference. It's not going to make a difference in a Social Security case.
Definitely important to know. And then what if we want to try working as a 1099 contractor? How do they calculate your monthly earnings? Because what I am paid is not my actual earnings after expenses.
Yeah, so there's a whole criteria for self-employment. I'm just going to generally say that certain expenses are going to be considered deductible for the purposes of that SGA number. And it really depends on your unique situation and what you think are deductible expenses to get underneath that number.
Okay.
Generally in those cases, what we'll do is we'll have the client who's asking that question submit to us their financial documents, including their monthly P&Ls, their expense and documentation, for us to generally get a sense of that. And then certainly, if it's close or questionable, there are times when I've actually submitted it as an exhibit when I'm trying a case, because I know the judge is going to ask questions about that just based on what's in the file.
And last one, would it help to submit approval for discharge of school loans due to medical disability?
So as you know, or as you may know, you can get your student loans discharged for what's called total and permanent. And part of the criteria is to have your doctor complete a form that kind of looks like they're answering questions about Social Security disability entitlement. The bottom line is that the Social Security Administration is not bound by that. And they're not bound, by the way, by VA findings or adjudications. So you have to understand that ultimately it is Social Security Administration's job to determine whether or not you meet the 5-step sequential evaluation. And so just because your doctor fills out a form that qualifies you for discharge of your student loans doesn't mean that it's binding on the Social Security Administration. I mean, I might submit it, but I'd rather submit an RFC form, quite frankly.
And just to reiterate, I know you discussed how alternative medication or alternative like providers like chiropractors and therapists aren't going to hold a lot of weight. Would you still recommend listing a therapist in the application or leaving it out?
Absolutely.
Okay.
I would always list every medical provider that you're seeing, traditional or non-traditional. I would prefer, as I've said, that my clients see traditional medical providers. If they wish to see non-traditional medical provider, it's only in conjunction with or in addition to traditional medical providers. Because one, as I've said, the Social Security Administration is not going to place any weight on anything they have to say. But two, it does show continuity of treatment and an effort to get better. So I want it to show continuity of treatment, but I want my client to understand that it's not going to, no opinion is going to, of the non-traditional provider is going to be accepted by the Social Security Administration. And that's why they need to continue to treat with a traditional, in quote, medical provider who would complete a residual functional capacity form. I have written a lot of books on Social Security, and I do a lot of disease-specific posts and web pages that are available for you. I do an ERISA podcast called Winning Isn't Easy, and I do disease segments. I've done a whole episode on POTS, by the way. It's from the perspective of an ERISA disability claim, but I think it's also helpful for anyone who has a Social Security claim.